Hi, everybody. We'll give it another 2 or 3 minutes for people to file in, but I just wanted to point out, if you weren't here in the session before lunch, that this session is being simultaneously translated into French, so if you would like a headset for that purpose, you have that opportunity. And also, this session is being broadcast to people joining at a distance. And so at a distance, if you have questions during the presentation, feel free to, you don't have to wait until the end. You can type your question into the chat, and then we will receive those and ask them of Stéfanie when she's done speaking. So we'll start in 2 minutes. So to those of you who have been kind of with us through the nursing program of this Congress, so yesterday and earlier today, welcome back. If this is your first session with us, welcome also. This is our last session of the nursing program that Bessie and I have organized, and so we're very excited to welcome Stéfanie Avery to present. Again, the context of today's seminar is really focusing on making a difference, critical reflections on the nursing role in palliative care. And so Stéfanie is going to talk to us about a study that she did where she interviewed parents of children who had died, and really focusing on the ways that nurses affected their experience. So thank you, Stéfanie, for being here. Stéfanie is a registered nurse and completed her master's degree in nursing at the University of Ottawa in 2019. For her master's thesis, she explored parents' experiences of end-of-life nursing care in the pediatric intensive care unit. She has worked in the pediatric ICU at the Montreal Children's Hospital as a nurse clinician since 2014, and she holds specialty certification in pediatric critical care with the Canadian Nurses Association. And once again, if you are joining via distance and you have a question at any time during the presentation, please type it in. Bessie and I will receive it and pose it to Stéfanie after her talk. So Stéfanie, welcome.
Thank you, David. So yes, as David mentioned, my name is Stéfanie Avery, and I'm now an assistant nurse manager in the pediatric ICU at the Montreal Children's Hospital. In this presentation, I'm going to share the stories of parents whose child died in a pediatric intensive care unit. More specifically, I'm going to share their perspectives about how nursing care shaped their experiences in this setting and how those relationships, really affected that experience. At the end of my talk, I want to have a conversation with all of you about all of your own experiences working with patients and their caregivers in all the contexts that you're coming from, and how your experiences compare with the stories that I'm going to share today. So please keep that in mind during my talk. I have no affiliation with a for-profit or not-for-profit organization. These are some of the competencies that I'm going to address today. So establishes positive therapeutic relationships with patients and their families that are characterized by understanding, trust, respect, honesty, and compassion. Engages with families during important life events to improve understanding of the patient-family experience and/or to mobilize support. And helps patients clarify their values and feelings, cope with uncertainty, and sort out their options for care. At the end of this presentation, participants will be able to identify meaningful nursing interventions from the perspectives of parents at the end of life and explore what constitutes an ethically significant nurse-parent relationship when a child is dying. Today I'm going to talk about how my clinical practice led me to want to explore this topic, and I'm going to briefly speak about the study design, and then I'm going to spend really the bulk of my presentation sharing parent stories with you. I will mention some of the considerations for clinical practice, and then after concluding my presentation, I would love to hear your questions and perspectives about my talk. So I'll give you a little bit of background about myself. My first job as a nurse was in the ICU. I started there as a new grad, and at the end of my very first 12-hour shift on this unit, a critically unwell child was admitted from the emergency room. To this day, I vividly remember the patient being admitted to the ICU, surrounded by a group of healthcare workers, with a member of the team performing compressions as the child was arriving on the unit. Moments later, the mother arrived and stood outside the room watching her child being resuscitated. Seconds after arriving, she collapsed to the ground, sobbing. Some of my colleagues went to her side to offer support. Over the next few years, working as a new nurse in the pediatric ICU, I observed how my colleagues cared for children and their families. I had no formal training in palliative care, and I often questioned how I might be able to best support parents during these situations. I experienced a lot of uncertainty surrounding this. In thinking about this topic and discussing it with my colleagues, I realized that regardless of their own years of experience, that a lot of them realized or experienced a lot of this uncertainty as well. These experiences and reflections led me to want to explore what evidence base and what existed out there to better support my own practice. As you all know, nurses are uniquely positioned to offer support to those in their care in comparison to the rest of the multidisciplinary team. This is especially true in critical care settings like the ICU, where a nurse may be taking care of one patient at a time. Because of this constant presence at the bedside, nurses impact children's end-of-life care and parents' grief in unique ways. Many parents have reported that an ICU hospitalization is very stressful and overwhelming. This is often because of the significant disruptions that occur to one's parental role when their child is admitted to this unit. As a result, a parent's sense of personhood and identity may become destabilized in the face of a child's critical illness. In my review of the literature at the end of life, where parents were interviewed about their experiences, although researchers were not focused on nursing specifically, these studies that explored parents' overall experiences often had themes about how central the importance of the nurse-parent relationship was at the end of life. Around the time that I was conducting the study, or that I was conceptualizing the study, there were a couple groups of researchers who published articles about the overall relationships between parents and the multidisciplinary team at the end of life. Yet what I found was still a significant gap was a specific examination of the nurse-parent relationship. So with my personal clinical experience and review of the literature, I chose to explore how nursing care influences parents' experiences of a child's death in the pediatric intensive care unit. I will not go into too much detail about the study design and methods. I'm happy to share a link to my bigger thesis work, or answer any questions after my presentation. I'm going to touch on the points that I feel are most relevant to give you an idea of the context that the study was conducted in, and how I collected data, and then who participated in the study. So for recruitment, after obtaining ethics approval, I contacted eligible parents by mail at least 6 months after a child's death. All of the parents who expressed interest in the study participated. Parents were recruited from a pediatric ICU and its associated step-down unit at a university-affiliated tertiary care hospital in Eastern Canada. In this setting, nurses have a 1-to-1 or maximum 1-to-2 nurse-to-patient ratio, and there are specific interventions that are offered to parents in this setting at the end of life, like a use of a memory box, where items such as hand or footprints or a lock of hair or any other items that parents might want to collect are assembled. And there are also cards that are left on the unit after a child's death that are left for the staff to sign. These cards are mailed to parents by members of the allied health team around 6 weeks after the child's death. I mentioned both of these interventions because they were mentioned by most of the parents that I interviewed. For data generation, I conducted in-person interviews with 11 parents. That was 6 mothers and 5 fathers of 6 children. I interviewed some parents in their homes, some parents in a private conference room at the hospital, and I interviewed one mother in her private office at the end of her workday. All of the locations for the interviews were chosen by the parents themselves. All of the parents participated in joint interviews, so they were interviewed together, except for the mother of one child whose partner chose not to participate. Before starting the interview, I asked parents if there was anything that they didn't want to talk about. I then started the interview by asking parents to tell me the story of their child's death. For some, this started with their experience of pregnancy, learning their child had a serious illness, and unfolded into their child's birth, and then their child's life and death in the hospital. For others, this meant sharing about their child's complex chronic illness and the multiple stays that they had in the ICU. Some parents had messages that they wanted me to share with the team. Others were participating in the study as part of the legacy they were creating in honor of their child. As you might imagine, the time I spent interviewing these parents was very emotionally charged. Despite the sadness, the anger, and whatever other emotions came up, parents had a lot to share about their experiences. The interviews lasted between 80 minutes, and one interview lasted as long as 4 hours and 20 minutes. Now I'm going to tell you a little bit more about the parents who I interviewed. So as you can see here, we have the parent pseudonyms, the child pseudonyms, and then age, their condition, whether or not they had previous ICU experience, how long their length of stay was in the ICU, and then the type of death that they had. In the first row are Denise and Jordan, who are Olivia's parents. Olivia was 8 years old and had a chronic illness. Her mother talked a lot about how her previous stays in the ICU and her experiences with nurses shaped their last stay on the unit. Olivia died days after treatment was stopped, and this treatment was stopped in the ICU, and she was transferred to the step-down unit before she died. Next, we have Leanna and Ian, who are Bella's parents. Bella was diagnosed with a cardiac malformation in utero. After she was born, she lived in the hospital, never returning home. After a few months in the ICU, she died following treatment withdrawal. Next, we have Catherine and Alexander, who are Lucy's parents. Lucy had a very rare genetic condition that resulted in her being admitted to the ICU several times in her young life. On her last admission, she died several hours after treatment withdrawal with her parents and family present. Nathan and Jacqueline are Emily's parents, and similar to Bella, Emily was diagnosed with a cardiac malformation in utero, was born in the hospital, and lived there until her death. Emily's death was unexpected, however. Both parents described that they were at home when they received a call that Emily had suddenly become unwell and they needed to come to the hospital as soon as possible. Nathan, her father, rushed into the hospital and witnessed the end of a resuscitation, while Jacqueline was only able to arrive after Emily had died. And then next there's Audrey, who is Francine's mother. Her partner chose not to participate in the study. Francine had a chronic condition and had been admitted to the ICU before her last stay. Francine died after treatment withdrawal. And then finally, there are Zachary and Judith, who are Chloe's parents. Similar to Bella and Emily, Chloe was diagnosed with a cardiac malformation before she was born, and she had surgery days after her birth. Several hours after being admitted to the ICU, Zachary and Judith were at home when they received a call that Chloe's condition had rapidly changed and they had to come into the hospital as soon as they could. Before they were able to arrive to the unit, Chloe had died. So now I'm going to go into sharing all these parents' stories. To give you a bit of an overview, the ways that nurses were most helpful to parents changed as parents' needs evolved. At times, parents wanted to assert themselves and be implicated in their child's care, while at other moments they desired nurses to lead them through times of uncertainty. Nurses fostered positive experiences for parents by recognizing when they might benefit from discreet, subtle support during the most intense moments. For many parents, this was during treatment withdrawal and immediately after their child's death. Throughout the end of life, parents valued nurses who conveyed that they cared about the child, their death, and the parents' experiences themselves. I conducted a thematic analysis and generated 4 themes from the data. I am still her mother, someone was taking us by the hand, she didn't fight alone, and she was just behind the curtain. In the next slides, I'm going to go into more detail about what each of these themes mean, and I'm going to present quotes from participants to illustrate them. The first theme, I am still her mother, is about the ethical significance of nurses' abilities to help parents realize their parental identity in the pediatric ICU in the ways they desired. Some parents describe being situated in the role of a spectator during their child's hospitalization. Many parents wanted nurses to assist them to safely be with their child. In the first quote, Leanna describes wishing that her nurses would create a space for her to be involved in her daughter's care. The quote reads, "To say I am able to work with you and you can work with me. I will leave you your place. You are the priority to provide care. And I know that your work is more important, but to be able to say, I am still her mother and I am involved." When nurses were able to recognize parents' involvement in caring for their child, this made a huge difference. For some parents, their abilities to parent their child in ways that were meaningful fostered feelings of empowerment in situations that were otherwise mostly out of their control. For example, in the second quote, Audrey describes a desire to help her daughter however she could and how meaningful it was for her to be able to do so. The quote reads, "Well, Francine was starting to have fever, so let's get some ice, let's get her temperature down. I will put ice packs at different places. You, nurse, do all the monitoring, and I want to help, so what can I do? I felt I needed to help. And yeah, the nurse, she was really good about letting me help and doing something for the situation. It was just super powerful." Ian similarly highlighted how his ability to contribute meaningfully to his daughter's care eventually helped him gain a sense of control and feel like a parent after previously feeling uninvolved in her care for most of her hospitalization and most of her life. The quote reads, "To not just be, okay, we're sitting in the corner of the room, we're watching what's happening, we're not talking much. To be told, implicate yourselves, participate in care, things like that, it helps. You have the feeling that you're helping your child even more so." While in most cases, participation in care was really central to fulfilling participants' sense of parental identity, such participation was not universally valued. For example, although Catherine appreciated that nurses recognized her as an expert in her daughter's care, she also appreciated when nurses knew to step in and take over certain tasks. That last week, I didn't have to participate in care at all, which was so much of a relief because I already had so much on my mind. It was such a burden on me. Lucy is dying. How is it going to happen? What's going to happen after? For Catherine, the nurse's ability to take over certain caregiving tasks allowed her to focus and be present for other aspects of Lucy's time in the ICU. In Catherine's case, such aspects included contending about what her grief might look like as she moved forward and thinking about the future. Jacqueline also explained how participating in physical care can force a particular kind of contact with her child's body that would be more harmful than helpful in her grief. After her child died unexpectedly, Jacqueline reflected on having not wanted to be involved in post-mortem care. It was better that it was the staff, a professional, who did it, because we weren't able to. In fact, I wasn't able to. I couldn't. Even if the nurse had asked me if I wanted to participate, I would have said no, because in my head already, I didn't see that Emily had died. I saw that she was still alive. I knew that she was sleeping. So to tell me we're going to give her a bath for the morgue and everything, no, I couldn't do it. In the following theme, participants described wanting nurses whom they could trust to lead them through unfamiliar situations. Such situations happened during especially important moments. Parents often did not know what they wanted or even what might be possible, and so they relied on nurses to help navigate through their experiences. From parents' perspectives, nurses offered emotional support while guiding them through the various choices they encountered. In this first quote, Ian, who previously mentioned wanting to be invited to participate in Bella's care, summarized the significance of having a nurse he could rely on during this period. The quote reads, "Someone was taking us by the hand, and okay, this is where we are going. The goal isn't pleasant, we don't want to go there, but having a hand to guide us, having someone who's bringing us there, that's nice for that reason also." Nurses who successfully guided parents in navigating the experience of a child's death used their judgment in assessing what parents needed as their situations evolved. As death approached, parents described how nurses checked in with them to explore what adjustments might be helpful. For example, Denise recalled how a nurse approached the question of whether the vital sign monitor for her daughter should be on or off as Olivia neared death. The quote reads, "There was really too much variation in Olivia's vitals, and the monitor wasn't making noise, but it was flashing, and we were getting so overwhelmed we were really stressed from it. And at a certain point in time, the nurse became aware of this, and she told us, if you want, I can turn it off, but only if you're ready for that." You know, she really asked us about it. She took the time to do that. It was another sign that we were getting closer to the end. For this mother, it's clear that the manner through which the nurse took the time to make such a suggestion, but ultimately left it up to her, was really significant, as she felt supported but was still able to remain in control of the decision. Parents highlighted that the ways that nurses offered guidance at the end of life affected how they experienced their child's last moments, as well as their ensuing grief. As Leanna describes, if you're well prepared before and you've done everything you wanted to do, you've expressed or you've spoken or you've really gone through everything, Then the hour where she died, it's almost just physical. Then after that hour, then it's bereavement. So I need to be ready for that. I don't have regrets. I have my things, I have all my mementos for the memory box, so I'm sad that I can look at all my mementos. You know, that helps a lot. In contrast to Leanna, Nathan did not have time to prepare for and reflect about what he might want, as his daughter Emily's death happened suddenly. In our interview, he shared with me that nothing else mattered besides having Emily back. Yet the nurses caring for him identified ways to create comforting memories of a traumatic experience. Because most of the time she was wearing a hospital gown, so we said to ourselves, we will take off the hospital gown and we will put on her pretty dress. The nurse took her things, and I would have never thought to dress her in that clothing. I needed it, but I couldn't think of it because mentally I wasn't prepared to take the right decisions at the right moments, since I didn't even know what the right decisions were. In this theme, participants described appreciating nurses who were both emotionally and practically invested in helping them live this experience as positively as was possible. Parents valued nurses who conveyed empathy, which for many was achieved by humanizing parents' experiences of a child's death. For Audrey, nurses demonstrated compassion through the ways they interacted with her daughter as they collected items for a memory box prior to treatment withdrawal. We were making her super comfortable and putting her with her stuffed animals and her blankets. They had a positive way about dealing with all of this. The nurses were talking. "Come here, my beautiful Francine. We're going to give you a nice haircut." And to take some snips of her hair for the memory box. It was just positive. It was cute and light, and because that's the way I would talk to my daughter anyway. Some parents also highlighted that nurses' gestures fostered the child's personhood beyond their death. For example, Ian described the significance of how after Bella's death, their nurse Emma offered to carry her body down to the stretcher her body down to the morgue rather than it being transported on a stretcher. A baby doesn't move alone. A baby is made to be in someone's arms. So to know that Bella was brought there to the morgue, I find that it proves that a nurse like Emma loves her work, and she takes it to heart. We aren't just patients, we aren't just parents. It was more than that at that level there. Just that she was brought there in someone's arms, for me was significant that she was accompanied until death and even further still. There was somebody with her and she was accompanied, and she wasn't alone in it. She didn't fight alone. Gestures that express nurses' emotional investment in what parents were living could also extend beyond the child's death after parents had returned home. Jacqueline, who previously spoke about how incredibly challenging it was to acknowledge that her daughter had died when she first saw her, described the importance of the messages she received in a card weeks after her child's death. After the funerals and everything, they sent letters of condolences, and everyone signed, and they wrote little messages to encourage us. And I found that was really wonderful. It proves that they really took it to heart what they were doing, that we weren't just like simple patients, that it really was something that they took to heart. Her husband, Nathan, felt that the support offered by nurses who wrote messages to his family after they had left conveyed their love for his daughter. It's not nothing. It's still something that's quite important to us. It proves, like my wife said, that for the nurses, it wasn't just, okay, one more patient and one more death. It was really a patient that was taken care of with love. The last theme highlights how the ways that nurses supported parents were manifested more subtly during the most intense moments. During the withdrawal of life-sustaining treatment and after the child's death, parents' experiences were positively shaped by nurses who simultaneously offered support while promoting parents' privacy. Parents described benefiting from nurses being able to work discreetly in the background. A nurse's discretion meant remaining present and engaged, but providing care that was invisible. In this quote, Ian emphasizes the importance of his nurse's ability to work invisibly. The quote reads, "Our nurse was present at the same moment that she was absent. As much as she was there to accompany, to be helpful, to do what she had to do, we were able to be my wife and myself with Bella and live that as if it was just the three of us." In the following quote, Nathan also highlights an instance of being present while absent. The quote reads, "Our nurse was right in the room. When we had asked for a bit of privacy, she had closed the curtain, but she was behind the curtain. She was constantly with us, constantly, constantly, constantly. She didn't leave us, not for 1 second. No, she was there the entire time, and she was just behind the curtain." It's clear from these accounts that discretion from nurses does not equate to disengagement or being withdrawn from the bedside. Zachary and Judith also highlighted the importance of their nurse's discretion after their child's death. In our interview, Zachary described how important it was to him that the nurse didn't impose herself during these moments. He reflected that the nurse's decision to give his family their space for privacy, following their request for privacy, was most helpful. The quote reads, "I think the nurse was very good in the sense that she was just there, almost like not there. Like I forgot that, but that was good, right? So she didn't interrupt anything. She just tried to be as helpful as she could." His wife, Judith, similarly emphasized how the nurse's ability to be invisible positively shaped her experience. The quote reads, "I think it was nice. It gave me time to be with my daughter, to be with Chloe, with minor interruptions. For me, I think it was better that way, that it was just more in and out and gave us the time to just be with her." Both parents described feeling that their nurse struck an optimal balance between remaining present and engaged while also promoting their privacy so they could focus on Chloe. The ability to have uninterrupted moments with one's child was highlighted as particularly morally significant for Bella's parents, Ian and Leanna. Time was incredibly important in the moments following Bella's death, as Leanna describes in the following quote. "I held Bella after the doctor pronounced her death. When we were ready, we gave her kisses, and after that, we put her back in bed. We let her go. I think that was really important also. It made a lot of sense to take her with us, to touch her and hold her, and after that, to let her go. It was something that we weren't able to do during her entire hospitalization for her entire life. It was always imposing everything, imposing a rhythm of care, imposing a rhythm of news, sad or not sad. It was always things that were happening to us, whereas then it was something that we were deciding, and we let her go in our own time. Time was important." I'll now present some considerations for clinical practice. Many parents in my study valued when nurses fostered their abilities to participate in their child's care. This can be accomplished in part by reflecting on our beliefs and values related to working with parents and all of those in our care, and on our willingness to collaborate with them and involve them in their child's care. It's also important for nurses to recognize and mitigate the inherent power differentials that exist in our relationships. In my study, some parents described feeling displaced from their roles as primary caregivers. To reduce these power imbalances, nurses must be prepared to engage in conversations with parents to identify how they envision their parental role, and must also be mindful that a parent's idea of what this means might evolve as their child's hospitalization unfolds. Although the focus of my study was on the experiences of parents, the nurse's experience is also really important to consider, especially when engaging with parents in this way and providing human nursing care. The type of engagement and personal involvement that parents valued in my study can be very challenging for nurses to provide. It can also be very enriching, but it can be very challenging. Nurses who choose to engage in parent suffering may also suffer themselves, and this can have potentially significant consequences. And professional and organizational structures need to acknowledge and respond to the suffering that nurses might experience while delivering end-of-life care. In my study, I wanted to reveal a relational ethical understanding of PICU nursing practice from the perspectives of parents. My study results revealed the subjective nature of nurses' practice at the end of life. Parents revealed that nurses could promote their parental identity through holistic, individualized interventions that supported parents to provide care to their child, prepared them for their child's death, and fostered their privacy during their most vulnerable moments so they could live the child's death intimately while still feeling supported by their nurse. Thank you very much for listening to my presentation. If you want to connect with me, there's a couple ways there to do so, but I'd love to open up to any of your questions that you have.
Do you want to go, Mahogany? Oh, yes? Okay, let me go first since I'm standing here. Okay, sorry. I have a question actually from someone who is joining us virtually. So it's Christina Ma who is asking, what are some of the lessons from your work with bereaved parents that nurses can bring to their role in other settings beyond pediatrics, where they provide palliative and end-of-life care to patients and families?
Thank you to Christina for that question. So I think I was alluding to it a little bit, but I think whether or not it's a parent as a caregiver or the caregiver who might be a husband or a wife or a partner or a son or a daughter of someone who you might be working with in another setting, I think it's lessons that I would say people might take away is to be open to engaging in discussions with these loved ones of the patients who you're caring for. To see how they envision their role, what types of care do they want to participate in, and then also recognizing or being mindful that what they say in one circumstance might change later. So not sort of assuming that they'll want to maintain the exact same role throughout their loved one's trajectory in whatever hospital or hospice setting.
So I was really curious about theme number 1, I'm still her mother, because you had a quote from a father there and several fathers that you had interviewed. So I'm curious why it wasn't I'm still her parent and why the emphasis on mother. So I just wanted to know if you could speak to that a little bit.
Sure. The titles of the themes that I selected were directly pulled out of some of the quotes that some of the findings that I had. So I took that specifically from the first quote I presented, which where the mother stated, I am still her mother. So it was not to necessarily emphasize mothers versus fathers. It was really just emphasizing the importance of parents being able to enact their parental identity in the ways that they find meaningful in the ICU. Yeah.
Thank you. So I just wanted to reflect a little bit on like the memory box piece, because I think it's so interesting as somebody who typically works with adults. And I think we sometimes get that so right with like pediatrics and the families. I just wanted to hear your thoughts on like how that could maybe be translated into like adult care and some of the ways that we do the aftercare for family members and caregivers or care providers even.
That's a great question. And I'll also highlight that although we offer the memory box to all of the parents of children who are dying, not every parent actually wants it or wants to use it. In terms of the types of things that could be collected or that idea, it might be taking photos with their loved one in that context. I think that can be very meaningful, and that's something also that parents in my study mentioned that, you know, my nurse suggested that I take photos, and I would have never thought of that, but now I look at the photos a lot and I'm happy I have them. So that could be something that could be suggested specifically for adult settings. But I think it also can be really individualized and tailored to the specific family members, and inviting them to consider what items they might want to collect to put into that memory box.
I just wanted to thank you for your very interesting talk. You spoke a bit about the differences, like the different experiences of parents versus withdrawal of care and like unsuccessful CPR and more precipitated, unexpected deaths. I just wanted to know, was there anything from a nursing perspective that was kind of brought out to the different role and the different ways that we can, let's say, collect those memories or kind of guide those parents through in a more rushed context? Because unfortunately in the PICU sometimes that's kind of our reality of having to do this whole guiding process very quickly. And I thought if you had any tips or anything that spoke up to you.
I think that from the parents that I can speak to the parents that I interviewed, and for the ones whose the death was really more unexpected and sudden, they needed their nurse to be more directive, to, I guess, propose or suggest things in a way that was sort of steering them in a certain direction. Because as one father mentioned, like, he didn't know, he couldn't make any decision at that time because everything was so overwhelming and he didn't know what to do. I would also just, like, again, caution, and in a way, like, the parents I interviewed, what was most helpful to them in one situation, that wouldn't have been helpful in another. So it's such a subjective, individual experience that I wouldn't want to apply, like, this works in all of these situations. It's really, it's very specific, but that's kind of the broad thing I would say.
So, Stéfanie, thank you so much for this beautiful talk. And, I think that, Lacey is sitting right there, and she just gave the talk preceding yours. So for those of you who are in the room for that one, I think that you have very nicely showed us how, these moments that we share with people at these extremely high stakes moments in their lives become part of their story, right? And become part of the stories that they will remember and that will last with them forever. So thank you so much for this work, for bringing us these stories. We're going to let you all go now because so this concludes the nursing session, and there might be other sessions that you want to go to that are probably starting at 2:45. So check your apps, and thank you very much for being here, and enjoy the rest of the Congress. Please fill out your evaluations.